someone at the 1604 campus could push their speaker, I'd like to see that you're connected to us, please. I see downtown.
Can you hear us?
And I need...
Can you hear us? Testing. 1, 2, 3.
Still there? Yes. Okay. So we have connection. I've visually seen and confirmed we have both 1604 and downtown.
The student mics down here don't appear to be working.
Okay.
But we can hear you and see you just fine.
Got that then? Okay, I guess we're ready to go. Let me switch over to the desktop first. I have highlighted on the syllabus today's date, October 10th, scheduled for the summary of the pharyngeal apparatus and review. Basically, we should be able to get through pharyngeal apparatus 2, lecture 17, and well into pharyngeal apparatus 3, lecture 18. The exam still is scheduled to be available online on Monday, and if we don't complete pharyngeal apparatus lectures today, we will go through it on Monday. Otherwise, we'll begin the respiratory system. I will be out of town at a scientific meeting, actually traveling to the scientific meeting on the 17th, and Marco has said that he'll work on the lecture Respiratory System 2 and be prepared to present at least a portion of it. So those are our plans. I will be back on the Sunday, so I'll be picking up the lectures on the digestive system. Please note that we are approaching the 24th, which is the last day to drop with a grade of W. Shouldn't be a concern for anyone because I give you the option of submitting your challenges or your rebuttal for questions to get reconsideration for credit. So if you're willing to do that work, you should be able to recover many, many points if you need them. But that is still a date to have in mind. If you're overcommitted or things are just happening, you can communicate with us and we'll try to work with you. But if it seems that it's really just not going to work out, keep that date in mind. Things are much more difficult to deal with if you let that day slip by. By that time, you will have completed 2 exams, and we'll be able to give you a summary of where you stand and what you might need to be able to do to try to achieve the grade that you want. This table on the syllabus, remember, gives you the assistance with making that determination. So as you get your grades on the exams, you should convert it to points scored, and if you want to get the grade of B, then you have to be able to get at least 398 points total to have a B in the class. So it's you can either look at it as percentages or as the points that you're collecting, and put those pennies in a bottle and see how close you will be after exam 2. And how many more pennies you would have to get from the remaining exams. Remember that we have 2 other exams, exam 3 and then the final exam. The final exam is 100 questions, each worth 2, so a total maximum of 200 points. So keep that in mind as you go through this. And as I had stated, at present, exam 2 will not be showing up for you, only the exam 1. It is showing there for me, but we'll get it finalized for you when the time comes, and it will show up as usual. I'll switch now to the document camera. I did remember to bring this page from the Time magazine that I had mentioned. So give a child with a cleft a second chance at life. So we see the nature of the deformity relevant to the discussions we're having now, and to whatever degree there is a defect, the surgeons are very highly skilled that participate in this, and they really can do a fantastic job to correct these types of defects. You will note that there is a deformation in the nose in this individual that they're able to correct to some degree as well, with a minimal appearance of scarring. So it's really quite a tremendous thing. There's a stat on here that I know you can't read, but I'll read it for you, that is quite impressive and pertinent in this situation. Today, millions of children in developing countries are suffering with cleft lip and palate, condemned to a life of malnutrition, shame, and isolation. So there is a tremendous impact worldwide on this matter, not just for the personal aspect of it, of an individual having isolation, but actually having difficulties with ingestion and thereby suffer from malnutrition. So our exercises to work with this are pertinent and really do bring some consolation to us that we can understand the challenges faced by everyone. I don't know if you're going to run off and donate $250 to this cause called the Smile Train. I'm not pushing for that, but just so you know my source. Kind of a cute little thing that they've got, Smile Train, 1877 Kids Smile. So I think that's a marvelous thing that humans that have privilege contribute to the world and to individuals that are tremendously appreciative of that. As I get to Brooks today from visiting a close friend in the cardiac intensive care unit at the University Hospital who is awaiting coronary artery bypass grafting, or CABG, the acronym. I know how lucky and fortunate we are in our society, so a bit of a mellow mood for me today, and we'll move on with that in mind. So I start here with this slide from lecture number 17 on the face. We did go through this, and I'll just quickly skim through them again to get back to the figure on slide 22 or 23 that we stopped at in the previous lecture. What we see, again, is the reference to the stomodium, the primordial mouth. The prosencephalic organizing center is going to be key to triggering development in this area. It migrated there from the primitive streak ventral to the forebrain. This brings us back to the reminder that the primitive streak, primitive node, primitive pit, all of these structures contributed to the establishment, along with the prochordal plate, of the polarity of the organism early on in the pre-embryonic disc stage. The appearance of the primitive node and streak were the first signs of the cellular proliferation to infiltrate between the epiblast and hypoblast layers. So we know that this fact that the primitive streak gave rise to these cells in the prosencephalic organizing center reminds us that there is a commitment of cells to a very important lineage very early on that has more to do with creating an organism that has polarity and structure than really just going someplace and turning into a cell that contributes to the formation of an organ. So it's a very elegantly orchestrated series of events and tremendous molecular and genetic revelations, if you want to think of it that way. And then as well, another organizing center at the point where the hindbrain, the end of the brainstem, will be meeting the spinal cord. There are 5 facial prominences that are being formed that are significant for our discussion on the formation of the face. The frontonasal prominence is unpaired in the midline, basically coming straight forward from the forehead region, if we want to think of that, giving rise to the optic vesicles that contribute predominantly to the eye and the orbit, the forehead, obviously, and the rostral-most portion of the nose. There's also maxillary prominences coming off from either side that we've seen. They're going to contribute to the lateral part of the mouth. We've already talked about them contributing to the zygomatic bone, the cheekbone, another word for it, and, of course, the upper jaw or the maxilla. So, obviously, that will be the parts of the lateral mouth that we are familiar with. And that mandibular process, prominences that are paired, that will form the caudal part of the mouth. So deep back, we have to close off the hard palate and soft palate to separate the nasal from the oral cavities. So as we take a moment and just press our tongue against the roof of our mouth, it reminds us that we've got a solid, bony separation from the oral cavity. And now if you'll just stick your finger up through your nose, you know that there is this separation of the nasal and oral cavities by the palate. So the floor of the nasal cavity is the roof of the oral cavity. So we have to bring some things in together from both sides, fuse them together to close off those 2 cavities and separate respiratory from digestive entrances into the organism. So the 4th to 8th week is where a tremendous amount of this is occurring, and the nasal placodes are going to pop up in week 4. These are surface ectoderm thickenings, and they are the primordia of the nose. So we remind ourselves, especially the guys that get hairy noses, just on the inside, it's the same type of skin basically as we have on the outside up to a certain point, and then from there on in, it's a different type of epithelium. Whenever we think of that and realize it, it's the same with the oral cavity, the nasal cavity, the auditory canals. Remember we talked about the external auditory canal and the internal auditory canal from the pouch, and the membrane in between forms the tympanic membrane, separating the outer from the middle ear cavities, and different sources of origin of the surface epithelium. Endoderm on the inside, ectoderm on the outside. Same thing in the nose. Ectoderm in the first part of our nasal cavities, the anterior choana, as they're called. And same thing in the oral cavity, back to the soft palate. We open our mouth and see the uvula hanging down back there. That tells us is the point where surface ectoderm coming in stopped from ectodermal origin, and the endoderm began. We'll see the same thing at the other end of the body at the anus, where the surface ectoderm contribution ends at a certain point, where it meets the contribution from the endoderm, forming the anal canal. So this is a common thing that we encounter. Not buttholes, but surface ectoderm meeting endoderm at certain areas. Well, nobody's falling off their chair laughing, so we'll let that joke pass. Okay, so back to this illustration, 24 days, the anterior view and the lateral view, and we are seeing these different prominences, the frontal nasal prominence in the lightest blue, the medium shade of blue, the maxillary prominences, those are paired, and the paired and already beginning to fuse mandibular prominences, and we see them from the lateral view here as well, and then the hyoid arch, or the second arch, is positioned there. We now go to 28 days, and we see that the nasal placodes have begun to appear, and the stomodeum is very obvious as the mandibular processes or prominences have fused together. The maxillary processes are pushing in to this area as well. From the lateral view, we see the elongation of the arches as the organism is growing in its entirety, and the maxillary prominence has not quite pushed into this area yet. But at 31 days from the anterior view, you see the nasal placode has triggered the development of the nasal pit, so it's going to push inward. And this is going to create that vestibule, if you will, of the nasal cavity where the surface ectoderm goes in. So we end up with hair follicles, a stratified squamous keratinizing with the hair follicles, the same as the guys get with our whiskers and other places on our body where we have hair follicles. And we see this change in the appearance of the frontonasal prominence, where there's going to be these wings around the margins of the nasal pit in this central portion of the frontonasal prominence. From the lateral view, we see the maxillary prominence meeting the nasal pit. We'll give more detail to the structures identified here. They come together to form the nasolacrimal groove, which ultimately we know will form the nasolacrimal duct, where our tears drain into our nasal cavity. That occurs on an ongoing basis, and we typically only notice it when we have watery eyes for whatever reason, crying or irritation or allergic response. Now we're going to day 33, and we're seeing a more complete fusion and relationship of the lateral nasal prominence as differentiated from the median or medial nasal prominence. Excuse me. And the continued formation and deepening of the nasolacrimal groove. So this is going to be a groove that gets deeper and deeper and then finally closes up, somewhat reminiscent of the formation of the neural tube. And then at day 35, even more complete closure of the junction of the lateral nasal prominence and the maxillary prominence, and we begin to see the medial nasal prominence with the rest of the frontonasal prominence pushing inferiorly, coming down to approximate the mandibular prominence that has completed its fusion at the midline by this 35-day period. From the lateral view, we see the external acoustic meatus and the external ear beginning to form below the second arch, the hyoid arch. So it would be the second cleft where this is going to begin to occur, and that ear is going to migrate back here posteriorly and a bit superiorly to take on its more adult location. Now we can see the nostril forming as the lateral and medial nasal prominences excuse me, are continuing to undergo the changes in development, taking on almost the appearance of a comma type of a shape, and the nostril becoming more prominent, and the maxillary processes coming in to approximate each other. But we see that the nasal frontal prominence with the medial nasal prominence intervening and preventing the maxillary prominences from fusing directly together in the front midline. You see the lateral view of the external acoustic meatus continuing to develop below the mandibular process. And then at 48 days, we can see the two medial nasal prominences that will merge with each other and with the maxillary prominences. So we can envision the lower lip being developed very nicely by the fusion of the mandibular processes, and the formation of the upper lip is going to be a bit more complicated, and we can follow that through with this illustration here. At 10 weeks, we see the nasal prominences have completed their fusion and give the more recognizable appearance of the nostrils, the external entrance into the nasal cavity. The nasolacrimal groove is deepening and falling into place between the eye and the nasal cavity. And there's an intermaxillary segment that's coming in to interpose itself just beneath the original nasal prominences, so the frontal nasal prominence basically fusing with the maxillary prominence, and then the formation of the philtrum of the lip. So this is that philtrum of the lip is that little indentation just below the nose, and it is, of course, really formed by the medial nasal prominence slipping into this area and fusing with the maxillary prominence that came in to form that intermaxillary segment. And of course, this becomes significant when we think of the malformations, because what we notice is that the malformations do not fall in the midline. They'll tend to be offset from the midline. So the philtrum is still present in this individual. So you can see that it is coming down as a separate structure and fuses on either side with the maxillary, the intermaxillary segment that is migrated into this area. So if there is a malformation, it typically will be off to one side or the other, or both sides of the philtrum that formed from the nasal prominence. So here we see that again, frontal nasal process with the medial, ultimately what will become the medial nasal prominence will fuse with the maxillary process to close off and have the philtrum form in this area. So we're following this medial nasal process and the maxillary process as they're coming together and form that philtrum. So we'll just quickly do the question here since this slide popped up as I switched over to lecture 18. So the philtrum forms by fusion of the frontal, the frontal nasal prominence and the medial nasal prominences. I may still have gotten that wrong, so you guys can beat me up later, okay? Gave it a good shot. If you find in the textbook that I was wrong, please inform me. The pharyngeal apparatus continued now with lecture 18 then. We want to begin to talk about the...
Which question was that you were referring to?
It's one of the slides in lecture 18, the formation of the philtrum.
Did that answer your question? What did you think was the answer? And what did you think was the answer?
First selection.
First selection, is that what it said?
We'll see it again when we come down through.
Okay, thank you.
So with that discussion, we considered the closure of the external aspect or the surface of the nasal and the oral cavity. We, as the discussion had progressed, mentioned that we are keeping in mind that the same thing has to happen deeper in so that we close off the palate we fuse structures to form the palate and separate the nasal and the oral cavities. So we're now considering the formation of this palate, the hard palate and the soft palate, to separate the oral cavity here, obviously with the tongue forming the floor, from the nasal cavity, for which the hard and soft palate forms the floor. The roof of the oral cavity is the floor, so that's pretty obvious to us all. And then we are now looking at the bony structures, the skeletal aspect of the hard palate, and we can see that there are different parts of this. There's a premaxillary part of the maxilla. There is the, of course, a suture, and then the palatine process of the maxilla, so two of each of these, and there are these particular types of immovable joints, the sutures, where these bony plates are coming together. And then there is the horizontal plate of the palatine bones, so there are different structures that contribute to the formation of the hard palate. Of course, there's also the superior alveolar process, which is the term for the structure that has all the holes in it for our teeth to stick into of the maxilla. So we want to follow a few events related to the development of this structure. So the primary palate is what we want to envision first, and then see how it will progress to forming the ultimate hard and soft palate. So we are thinking in weeks 5 through 12. So in weeks 4, we started to see structures moving forward to form the face, thinking of it from the surface primarily. Now we'll take a look internally, starting with week 5, to see what happens. So there's a median or midline palatine process that's going to develop between the maxilla coming in from each side in week 6. And this becomes a minor component of the adult hard palate, but it is significant in the formation at this stage because it falls into place and is there to basically make contact with other structures coming in this area and contribute to the initial locking down of everything and targeting or initiating the fusion process. What we're going to be looking at is a few sections that will be in the coronal plane, so cutting, if you place the knife so it would go from ear to ear, so you're going to be cutting this way and basically lifting the face off and then looking in to the nasal and the oral cavities. So it's a coronal section going to be made in this plane, and then we'll be looking from the front inward into the nasal, developing nasal and oral cavities. But first in panel B, we'll take a look at the underside of the palate, the hard palate, and we can see that there are a variety of structures in this area. So we talked about the developing upper lip. We know that the upper lip really does change a bit, even though it has the same surface epithelium of ectodermal origin, stratified squamous epithelium. We have slightly different type with hair follicles. We all have the hair follicles. They just grow bigger in the males, of course. In the skin above the upper lip, then it changes to the smooth, but still, especially this time of year where our mouths are more likely to dry out, we get the chapped lips. So we know we can get the keratinizing very easily of the lip itself. And then when it turns and goes toward the gingiva, the labiogingival lamina shown here, it changes to a thinner type of stratified squamous epithelium. And we know that because if we lift our lip up and look at it, we can see the blood vessels underneath it. So it's going to thin out a little bit and remain moistened at all times. But still, it's the same stratified squamous epithelium, several layers of flat cells, just not so many layers, but still several layers. And is of ectodermal origin. Then we can see some other structures, a median palatine process that we mentioned, a nasal septum that's beginning to drop into place. We're kind of looking through this kind of a mirror or a glass window type of a thing. We see the site of the fusion with the lateral palatine processes that are beginning to swing into this area. So these four structures, the two lateral palatine processes, the nasal septum that's dropping into place, and the median palatine process are all going to come together and join in the midline, and they should fuse together and seal things off. So here is that coronal plane of section in panel C, and then still the horizontal, the inferior view from in panel D, and we can see that the nasal septum is dropping down. We're not in a plane of section. We're too far deep into the head to see the median palatine process, so our plane of section is farther back here, where we should see the two lateral palatine processes and the nasal septum that's up above there, but our plane of section is not forward enough to see the median palatine process. So we see that nasal septum dropping down in toward the tongue, and then the lateral palatine processes moving in. They're eventually going to have to get themselves above the tongue, come across, and meet with the median palatine process anteriorly toward the front, and with each other and the nasal septum in the midline. So the secondary palate will begin to form. It's the primordium of both the hard and the soft palate of the adult. It's formed from the lateral palatine processes, so we've already seen those moving in, which are part of the maxillary prominences. So the maxillary prominences are contributing this aspect to the formation of the palate. It starts as the projections lateral to the tongue bud, but they ascend as the tongue becomes smaller. So we saw how they're going to have to move up above the tongue in order to come and fuse with each other. So we see the tongue bud getting a bit smaller and dropping some as the head is growing and the foregut is developing and the neck and the thorax. And so these lateral palatine processes are more readily able to approximate each other. We see the cartilage being laid down for the site of osteogenesis to produce the hard palate that will infiltrate into this lateral palatine process. They have to fuse and close this space off, and then we see the nasal septum dropping down, so they're getting close. We also see, of course, on the lateral walls of the nasal cavity, these bulges that are coming in that are going to form the nasal concha, the turbinate bones within those we are familiar with, to create this airflow chamber for the respiratory system. And this is the digestive system, so it's very important to separate these two. And we see in panel F on the right that the lateral palatine processes have met with that primary palate, the median palatine process, and their fusion is rather complete there, and it's continuing from from anterior to posterior along these lateral palatine processes. And when they meet, their final point of fusion, of course, is going to be the soft palate at the formation of the uvula. So now we can take a look at an illustration of an actual histological sample. And first thing we note is the tongue bud and the nasal septum pushing down in here. There's a cartilage inside it called the vomeronasal cartilage. Cartilage laid down first before any bone, but of course the lower part of the nasal septum is there's the anterior and superior part of the nasal septum is cartilaginous, so not all of this cartilage is going to turn into bone, is the point being made here. You see the surface epithelium on these structures. It's a respiratory epithelium up here, and then it is going to meet finally with these lateral palatine processes that will be positioned above the tongue as soon as the tongue bud drops down and becomes smaller. And this fusion has to become complete for the successful separation of these chambers all the way to the point of forming that little thing that hangs down the back of our mouth, the unpaired uvula. So here we see that question 7, the philtrum. And at the moment, I'm still going with the frontal nasal prominence and the medial nasal prominences coming together to form that philtrum. So the median palatine process becomes what? So we saw that it contributes to part of the hard palate. So the very early illustration showed us that it's contributed to the hard palate. So continuing with this discussion of the secondary palate then, the processes fuse in the median plane. We saw that that was essential. The concurrent growth of the vertical nasal septum comes in and links this all together to separate the right and the left nasal cavity from the oral cavity as well. And there has to be that complete fusion of all of these structures by within weeks 9 to 12. So there's a critical window is the end of week 6 and the beginning of week 9. So if something happens at any of those 2 times to disrupt this, you're going to get an incomplete fusion. Now we're going to take a look at figure 10.8, look at some coronal sections of the human embryonic head, showing that palatine process, the shell developing during the 8th week. This would be a time when the embryo has a crown rump length, another way of staging the embryo of 24 millimeters. And in panel A, the section shows the early development of those palatine processes. The scale shows 6 units from the lowest point of the nasal septum to the floor of the oral cavity. And then in B, we're going to see the embryo of a crown rump length of 27 millimeters, just 3 millimeters growth in length, linear from crown to rump. And that section is going to show the palate just prior to the palatine process elevation above the tongue bud. And the scale will show 10 units from the lowest point of the nasal septum to the floor of the oral cavity. So the floor of the oral cavity is dropping away from the nasal septum, even as the nasal septum is growing inferiorly to find a point to fuse with the lateral palatine processes. And then in panel C, we'll see the embryo with crown rump length of 29, an additional 2 millimeters near the end of the 8th week, and the palatine processes are elevated and fused, and then the scale will show 12 units, so an increased top to bottom length overall distance from the lowest point of the nasal septum to the floor of the oral cavity. So here we see this panel A. We see the distance from the nasal septum to the floor of the oral cavity below the tongue bud is 6 units. And that distance is going to increase even though the nasal septum is going to grow inferiorly, ultimately to meet these 2 palatine processes. This means that the floor of the oral cavity, including the tongue, is going to descend as we get a lengthening of the neck and the lowering of the larynx and the hyoid bone to which the tongue is attached into the neck region. So here we see increased distance, even though this is actually lowering and approximating where these 2 lateral palatine processes are going to flip up and fall into place. So the tongue bud at this stage is still quite prominent in this area. And then finally, the tongue and the oral cavity, the floor of the oral cavity have dropped. We've got 12 units of measurement in that area, and we can see the inner portion of the maxillary process that became the lateral palatine processes are coming together, beginning to fuse with the nasal septum. And of course, already rostral to this, they will have fused with the median palatine process. And we see basically the cheek over here that has formed. And of course, this pouch will be contributing to the structures that it forms over there. And we see the tongue very well developed. So now we can specifically discuss some of the abnormalities or the deformities that form from aberrations of the events that we have just discussed. So cleft lip actually has quite a high occurrence of 1 in 1,000 births. So this is percentage-wise not very high, but when we think of these types of events, it is significant. And as we saw in the that page from Time magazine, that there are millions of children in the world that are born with this defect. So when we think of worldwide, 1 in 1,000 is quite a few. So the general incidence in males is about 60 to 80%. So there seems to be something going on that is related to the gender of the embryo and fetus. The unilateral cleft lip caused by the failure of one maxillary prominence to fuse with the medial border of the nasal prominence. So we said when these two come together, they will complete that formation of the philtrum and the completion of the lip, the upper lip. The bilateral cleft lip is caused by the failure of both of those maxillary prominences to meet and fuse with that medial nasal prominence. And this is less common than the unilateral that we saw in the illustration from the magazine. So right now we're discussing only the cleft lip, so the failure of the fusion of the maxillary prominences with the medial nasal prominence. There's usually some type of genetic predisposition to this, but other factors might be involved as well. Possible also to have a combination of abnormalities so that there are errors in both lip and palate fusion. So there can be incomplete fusion that would be more than just a cleft lip. It could be a cleft palate. So this occurs a little bit less frequently, 1 in 2,500 births. It's more common in females. It's caused by failure of the lateral palatine processes to fuse together. And I think that's obvious from the illustrations we just examined so carefully. So there's usually some genetic predisposition for this as well. So we are now going to take a look at figure 1044. These are photographs illustrating congenital anomalies of the lip and the palate. And we will see a complete unilateral cleft of the lip and the alveolar process, the hard palate, and a complete, in panel B, a complete bilateral cleft lip and alveolar process with the bilateral cleft of the anterior palate. And then C and D will show bilateral cleft of the posterior and the secondary palate with a normal lip. So there's a variety of variations, a spectrum of variations that can occur. So here we see on the left side of this individual incomplete fusion of the maxillary prominence and the medial nasal prominence so that the space is open. And this extends. We can look way in and see that there is no hard palate back there either. There's a malformation of the maxilla. You can see the oddities of the superior alveolar process where the teeth will be. On the right-hand side, it is complete, and we can see the philtrum in here, even though it's obscured a bit. Panel B, we see the bilateral failure of fusion of the medial nasal prominence with the maxillary prominence coming in here. However, the philtrum would still be complete. This would be that frontonasal prominence as part of the medial nasal prominence as well. We can see that there is malformation, bilateral malformation of the hard palate extending back into the oral cavity. Here the lip is retracted, so it's the upper lip is completed, but we can see a split. The median palatine process is here. It would have fused with these lateral palatine processes. At the free edge of the lateral palatine processes, we see angle laterally as we proceed posteriorly deeper into the oral cavity, so there's no uvula sticking down here with the soft palate that we're accustomed to seeing. They're just the free margins of the lateral palatine processes that did not complete their extension all the way to the midline and the fusion. So we know dorsally up above here in the nasal cavity, the nasal septum will be dangling, hanging down in that area. Then here is another view of this, where we see the soft palate had formed to some degree but not fused in the midline, so it almost looks like two uvula. And here's that free margin of the palate, the hard palate. So we could see where the median palatine process would have been, the lateral palatine processes. So there's a fusion to some degree there, but there's almost a complete failure of the lateral palatine processes to fuse in the midline to form the hard and the soft palate. You see this structure up above, because we're from below looking superiorly. So this would be the nasal septum that's hanging there, wishing that it had met with and fused these lateral palatine processes. There are other disorders associated with the pharyngeal arches. They're not just the cleft lip and cleft palate, as we saw. There are others as well. So there can be congenital anomalies of the eyes and the ears and the mandible and the palate. So we saw that all these structures, the optic disc and the nasolacrimal groove and the medial and lateral nasal processes, the frontonasal process, maxillary prominence, they all have to come together to close off all of this area on the sides of the face. And if they don't come together and fuse to whatever degree or extent, we can have all kinds of anomalies of the face being simply wide open, straight into the nasal cavity, the nasolacrimal duct, into the oral cavity, the orbital cavity, and so forth. This is typically the result of insufficient migration of the neural crest cells, so they don't trigger these events of the bulges forming and migrating toward the front and the midline. This will typically be a genetic type of an anomaly. And the one final one that we'll mention, the DeGeorge syndrome, it's a congenital thymic aplasia. There's an absence of the parathyroid glands. This already is telling us it's going to involve the pharyngeal pouches, occasional ectopic tissue. It's characterized by a hypoparathyroidism, impaired immune response because we don't get the thymus, shortened philtrum, and thyroid hypoplasia. So tremendous conglomeration of problems clinically caused by a failure of the third and the fourth pouches to differentiate. And it is a result of a deletion, mutation, or a teratogen. So this final question, which of the following is a facial deformity? It would be the cleft lip. The The cleft palate, the DeGeorge syndrome, and the thymic aplasia typically do not involve the face. So when we ask for facial, you have to be able to see it on the surface. So the DeGeorge syndrome has a shortened philtrum, but that would not be really a significant facial deformity as the cleft lip would be, as we've seen in all of the illustrations. So we were able to complete lectures 17 and 18 today. So then on Monday, we will begin the first lecture of the respiratory system. If you have questions on the lecture material relative to the questions within the chapters, come in with those questions, and we'll give every effort to deal with your concerns. I do have business on the 1604 campus on Monday, so I will be lecturing from the 1604 campus. So I'll see you there. Those of you downtown, we welcome your attendance and questions on Monday as well. I will come prepared to present on the respiratory system as well. A reminder, we will have the exam posted as of the end of Monday's lecture, and we will extend it through midnight on Wednesday. So on Wednesday, when you come to class, if you have concerns, bring those to our attention. Also use the Lec17 mailbox. Both Marco and I will be checking on an ongoing basis for problems. He saved my butt and yours last time, so I appreciate his assistance with that. You all have a nice weekend. Think of me working endlessly on this grant proposal, and that good things will come from it. And say a few prayers.